Oh, Dr. Yeah, Dr. Vazquez, I'm on, okay?
Welcome, welcome. We're just waiting for others in the audience to start logging on too.
Okay.
To those that are joining, we're going to wait a few minutes just for everyone to join in before we get started. So we're going to give people just a few more minutes because we have a very large number of people who are going to be logging in. I'd like to, I know some people are still logging in because we're expecting a large number today, but let me just go ahead and get started and deal with some of the logistics and the basics. I'm Meg Guerin-Calvert, one of the co-chairs of the Action Collaborative. And on behalf of the co-chairs of the Action Collaborative on business engagement and building healthy communities, I'd like to welcome you to this, which is the 5th webinar of 2020 and our 3rd for the Action Collaborative on the topic of community responses to the COVID-19 pandemic. The collaborative is an ad hoc activity associated with the Roundtable on Population Health Improvement, which is in itself a convening activity launched in 2013 by the National Academies of Sciences, Engineering, and Medicine. For those that are new to these webinars, the collaborative is a flexible and action-oriented group that welcomes all interested organizations and individuals, and we welcome those that are participating on the call today or have participated in past ones. Our purpose is really to try to catalyze and facilitate private sector partnerships and actions of business, health, community, religious, faith-based, and public sectors to work together to enhance the lives of workers and communities by improving the nation's health and wealth. And as you can tell with our prior webinars, but particularly with this one today, that it is even more important that these kinds of health collaboratives, today specifically speaking to faith, community, and government collaborative, play ever increasing roles in COVID-19. Again, to give you just a little bit more background, it will be posted on our website. Our next webinar, also on a COVID-19 related topic, is on July 21st at 1 p.m. Eastern. Alina will put the link in the chat. And let me just tell you, we tried to title it a little bit provocatively. It's called The Antidote to Pandemics, Population Health Leadership and Action, and it will feature 3 leaders from the San Diego County Health and Human Services Agency sharing what they've done, robust and deeply rooted cross-sector partnerships that have been central to their specific COVID-19 efforts. Before I introduce this great session today, just a couple of logistics. You can see down at the bottom of the screen that you've got a Q&A option. We'd really appreciate it if throughout the session, if you have questions that you would like to pose, If you could do so, we are leaving definitely time to address those today. If you have a link to share or a general comment, please do use the chat function. We have found on our prior webinars that that's a great way to share ideas, immediate reactions, which is of great benefit to the speakers, but also to all of us afterwards, and we'll compile and make those available. So let me now turn to our topic today, which is Faith, Community, and Government Health Collaborative to address health disparities during the COVID-19 pandemic. What you're going to hear today is just a remarkable story of how a particular collaborative came together to address the significant impact that was there already, but the additional significant impact of the COVID-19 pandemic on African American and other populations in Buffalo, New York, and the Western New York area. I won't give away any more of the story, but let me tell you who our speakers are today. If you could go to the next slide. On the next slide, the speakers are Maria White, and not necessarily in this order, Maria White, who's the Deputy County Executive of Erie County, Reverend George Nicholas, who's pastor of Lincoln Memorial United Methodist Church, Dr. Raul Vazquez, who is CEO of Greater Buffalo United Accountable Healthcare Network, and a variety of other organizations very engaged in primary care and addressing the needs of this population. And they are going to speak to what their collaboration had as their main issue and what they did. We have the wonderful aspect of having Gary Gundersen from Wake Forest Baptist Health with us. And how we're going to organize this webinar today is the three panelists will speak and share their story, go through what they've done. Gary then will provide some comments and have some interactive discussion with them. We will then, somewhere right around 2 o'clock, maybe a little bit before, we've reserved a full half hour to answer your questions and pose your questions. And so if you would go ahead and add those, that we will go ahead and do that. With that, Pastor Nicholas, let me turn it over to you, and I will put myself on mute, and very much looking forward to this.
Thank you so much, Meg, and Reverend Gundersen, and the rest of you all who are viewing on this webinar. Let me first say good afternoon to all of you, and we're so grateful for this opportunity to share with you some exciting things that are happening here in Buffalo, New York. And let me preface this saying that this is a work in progress. So by no means are we taking a victory lap, but we also want to share with you some tremendous progress we've been making here in this region as it relates to, the health of Black and Brown people. Let me just kind of share where we are in terms of how we got to this point. About in 2014, 2015, we had a conversation with this one young lady named Mary Walls around colorectal cancer and how do we get information out into the African American community around colorectal cancer. And I posed a question to her. Let's dig deeper, right? Let's not just focus on one particular chronic disease, but let's look at what is the general health of it at that point, African Americans in the city of Buffalo. And let's see if there's a common thread as it relates to chronic diseases. And so what we did, it was a small group of us, mostly clergy and a couple other community leaders. And then we reached out to some other technicians who could help us look at state and county data and make an assessment on what was going on with the health of Black people in the city of Buffalo. after we did this research, or really we didn't do our own research, we just were able to pull, and that's one thing. The data, the information that you need is really at your fingertips through your municipalities. You just got to do some digging and figure out what's going on. And when we looked at the data, we realized that in the 5 or 6 zip codes where about 80 or 90% of African Americans lived in Erie County, so Buffalo is in Erie County, that there was just a tremendous health disparity around every chronic disease. When you're thinking about diabetes, heart disease, cancers, asthma, all these types of things, that African Americans were off the charts in terms of the health disparity. And when we looked at the data closer, we realized that African Americans were 300% more likely to have a chronic disease if they lived in those communities versus a white person who lived outside of that community. And that translated into 10 to 12 lost years of life. So literally, African Americans were living shorter lifespans, and the quality of their life, many stricken with dialysis and all kinds of numerous medical conditions. And then we looked at why is that? Well, you know, the Center for Disease Control, the World Health Organization, all credible groups will tell you that the main factor that influences the health of a community are the social determinants of health. Now, for some of us, that may seem obvious, but for the city of Buffalo at that time, as it looked at the health of Black folks, there was a lot of finger pointing. There's a lot of blaming. Well, Black people are sick because, you know, they eat too much fried chicken at their church dinners. They don't exercise. They don't do all these other things. And so we had to shift the narrative. We had to say, listen, it's the social and lived environments that are driving these poor health outcomes. We lived in a community where, you know, 40% of Black Buffalo lives in poverty. Over half of our children are in poverty. The unemployment rate for Black men is 4 times that of white men. The air and water quality in our communities is significantly, we have sections in Buffalo where actually the water quality is worse than the water quality in Flint, Michigan. And so you had all these factors that were concentrated in these neighborhoods. So it was a natural progression that you would have poor health outcomes. So we began and put together this thing called the African American Health, and at that time, Health Disparities Taskforce. We reached out to Erie County Medical Center. We reached out to the University of Buffalo, and let me park that real quickly right there. Historically, Buffalo and the University of Buffalo have not had a strong working relationship. There's been this tension between the Academy and the Black community in terms of there really not being that kind of working relationship to try to solve problems within the Black community. And in some ways it was also hostile because you would have research projects where Black people were the subject, but we never received any benefit from the results of the research. But I reached out to them. And one of the things that, you know, as we look at learning things, if there are institutions within your communities that have not been historical good partners with the Black community, don't let that history prevent you from holding them accountable and making them work with you on current challenges and problems you have within your community. So we reached out to the university and said, listen, we have these serious health disparities. You are the big university. They just opened up a major medical school that was built right in the east side of Buffalo, right in the Black community, right? And there was this tension there that here you build this multi-million-dollar, it might be $1 billion facility, right there on the east side of Buffalo. It was disrupting the neighborhood in a lot of ways, displacing people. It was having an impact upon the infrastructure, the water. There people were flooding in their basements. And so we said to them, they said, listen, we have this big problem. And universities are designed to solve big problems, to tackle big questions. So we need you to come alongside of us and help us address these issues around the social determinants of health. We need you to be a university that's going to be a good partner with the community. And not to my surprise, because I have a lot of faith, I am a pastor, that they came in, and not only the medical school, but because we were talking about the social determinants of health, we had to brought in the School of Management. We brought in the School of Social Work, the School of Nursing, the School of Education, the law school. All the major schools within the university structure came around the table with us as we constructed this African-American health, at that time, Health Disparities Task Force. We looked at the data and we made a claim to do three things real quickly, then I'm going to take it over to Dr. Vazquez. One, we wanted to establish or institutionalize this task force, make it something that was ongoing, and making sure that we had the right community partners around the table to look at this issue. Two, we wanted to establish a center around African-American health disparities, an independent 501c3 institution that would do research, advocacy, programmatic development, and strategic planning around how we can begin to move systems to have a positive impact upon the health of Black Buffalo. And then thirdly, we wanted to push the university to embed something within your university that would focus on doing intense research around these issues and be a community partner, sharing your data with us and coming up and helping us come up with programmatic and responses to some of these issues. And the good news is we've accomplished all three of those things. And the good news is in process right now, we are working on those. We've established the Buffalo Center for Health Equity. Why the switch? We decided to change our language from health disparities to health equity to speak about the aspirations, to speak about where we want it to be. The University of Buffalo established an institute at which in the university structure, that's the highest level, an institute that would focus on the health disparities on the east side of Buffalo. And we would partner with them. So they would be the lead on a lot of the research. But what was so great about it is they brought all the different schools into this institute structure. And so we are working right now, on the social determinants of health. How does this relate to COVID-19? When COVID-19 became apparent nationally, we realized, when I talk about we're talking about this group, this African American Health Equity Task Force. We realized because that diabetes, asthma, and heart disease made people more vulnerable to COVID-19, we already had our own data that showed us that in the African American community, those three areas, diabetes, heart disease, and asthma, again, in Erie County, was off the charts in terms of prevalence with Black people. So we realized, that COVID-19 was going to hit our community hard, and we had to be prepared. We also knew this: the existing health systems were not sensitized, or the priority of Black health would not enable them to be able to respond in the right way. So we had to push these systems, and Maria will share a little bit about that. but we called a phone meeting with some leaders, well, specifically with the county executive, who is the Erie County Health Commissioner, and the county is over public health in our region. And we said to them, we said, listen, COVID-19 is on the way, it's here. What's your plan to address these most at-risk communities? And they didn't have a plan, not because they were bad human beings, but they kind of had this they had to think about the whole county. So we said to them, listen, we'll come up with a plan. We'll develop a plan and let us partner with us and make sure that we have the resources that we need in order to take care of our community. But you have to come alongside of us. You're not just going to hand this off to us, but you are going to allow, but to partner with us so that we can address the issues in our community. Fast forward to the good news, and then Dr. Vazquez will describe more about how we did that. The first numbers.
Do you want to go to the next slide, perhaps?
Sure. And I'll just give me one more minute, and I'll get you where we need to go. You'll be ready, Dr. V.
I didn't know whether you were sharing the good.
Okay, so when you look at these numbers, and Maria will tell those stories as well. If you could look at those numbers, the first set of numbers that came out were in alignment with what's happening nationally. That Erie County being about 14% African American, 14.6%. But our early fatality rates were running at about 2.5 to 3 times that, right? And that's pretty much what's happening around the nation, and in some places even worse. But also you can see from that chart, because of the work that we do and the collaboration, and I can't impress upon you enough the importance of collaboration. And the other big point here is strong Black leadership that Dr. Vazquez and his organization, who is what they would say minority owned and operated, but a partner, and not only a partner, but a member of our community who has been doing work around the issues of community health and the social determinants of health and helping those who are most at risk. He didn't have to get introduced to these issues. He was already on the front lines working on those things. So he was appropriate to provide the leadership on the clinical side, on the health side, not the institutions that hover over our community, but they need to be a player. They need to help, get us resources and what have you. But the leadership had to come from the community, the Buffalo Center for Health Equity, and Dr. Vazquez and his organization and operation. And as you can look at that data, and he will share more about that as well as Maria, as you can see, we in Buffalo are trending in the right directions in terms of reducing the fatalities of African Americans in our region, and almost having them in alignment with the population of our region. There are very few communities in America that can say that at this moment. And so we're happy with our progress, but we're not satisfied with the condition of the health conditions of our people. So we will continue to be diligent and work on community health, because we are unapologetic that our goal is to eliminate race-based health disparities. We don't believe that your race should be a determining factor upon your health. So now let me turn it over to my good friend, partner in crime. And you'll know, if you're from Buffalo, the fact that Dr. Vazquez and Pastor Nicholas are working together, that makes a whole lot of people in this town really uncomfortable. Because one thing, and I'll just say this because he won't say it, there were those that would come to, that that as we began to reveal these situations, they say, Pastor, we'd love to help you. Yeah, you know, we're concerned about, we don't want to see this disproportionate number of Black people to suffer in your community. And so we're willing to invest in you, and what are you trying to do, and how do you get this thing done? But, you know, you can't have Dr. Vazquez lead that. And I'm just gonna say one thing, I've got that age now, Reverend Gundersen, where I don't sugarcoat stuff anymore. You know, when you're a younger pastor, you try to dance around stuff. And because they said, well, we'll do this in this organization. And I'm thinking to myself, I say, wait, I haven't seen none of y'all trying to help Black folks before COVID-19. And so why would I turn my back on a brother who's been doing this work just because you don't have a comfort level, you know, with you know, his brilliance and his expertise. And so we stood tall, and, you know, Reverend Gundersen, you know, I know how to, sometimes when you speak in tongues, some of those tongues are not the kind of tongues you hear in a church, you might hear somewhere else. But sometimes you got to stand up for folks and make sure that, no, we understand how we can help ourselves, and we just need you to play fair and make sure that the resources that are coming into the region, that our community gets their fair share. So tee that up for you, Dr. V. Tell them the brilliance of the work and how we set this thing up, and we'll go from there. God bless you. Thank y'all for giving me some time.
Thank you, Reverend. If we could go to the next slide. I appreciate those words, you know. I think for us, we were going through, you want to go to the thing, next slide? Next slide. Next slide. Next slide. Keep going. I think it's, yep, right here. Okay, so I think what we did was when all this happened, I mean, you know, the churches are often the trusted entity in both the Black and brown communities. So I've always, you know, it's my heart. I don't do church's work, but I support it. I think, like the Reverend said, I tend to be someone that ruffles feathers because it's the right thing to do sometimes, and to make sure that we don't forget those that often don't have a voice in the room. And that's always been my concern. I've been practicing in this area for 30 years. So it's what I chose to do. I chose to go into primary care. And I believe that when this came about, since we're rooted in the community, we do so much work, we were able to really have a big impact. The next slide, please. So what we did was develop this community response, and we were looking at creating different sort of buckets at the time. We had somebody that was dealing with population health because we had data on 30,000 lives. We were developing the testing because testing became an issue at that time. It's another issue now again, but at the time there was almost no testing going on. Treatment plans, we were trying to figure out, while we didn't know what to do, there was a lot of discussions in the media. We wanted to make sure we had a team that was learning about the disease and also coming up with the right sort of treatments to kind of let the individuals know, the community, because the communities a lot of times are not too accepting of medical information. So there's not a lot of trust with hospitals, not a lot of trust with health departments. And when you try to reach them, that, you know, there's a lot of people that call bill collectors things that they will automatically basically hang up. So when we met, we were just trying to kind of bring a lot of groups together, but with the focus of really urban family practice. My office had been running a drive-through testing. We were just trying to keep up with the supplies because there was not enough supplies at the time. So that was one thing. We took the data out of at least our portion of the individuals, which was about 15,000 lives that we're managing through care coordination. And we infected those 15,000 lives with information so they can tell 3 people. And I think that was the beginning of really informing the community that something had to take place. We looked at high risk individuals, you know, we looked at people that really were affected by social determinants of health, and that were also that would have the potentially to get into trouble, and basically did massive calls set up telehealth. We shut our offices down in March. So in March, our practices, our care coordination, everything went to telehealth because we knew if we kept these places open, we were just kind of spreading the infection. And we were looking out for the community, also looking out for staff. And to do this work, you were going to need people that were not running into this issue. PPEs were not very available. And because we're in primary care and we're grassroots, we don't have access to it. Our hospitals were hanging on to it. You know, the county was hanging on to it. So there was just this there wasn't the connection. I think once we had our meeting, we talked to kind of tell them the issues that happened because, you know, the county and all the information was saying, go to your primary care. So, you know, if these offices were not open, where do you go? If you don't have a primary care, which zip codes like 14215 had, where do you go? You can't be tested. Next slide, please. So our model for this was designed in this fashion. It's let's do the chase list. Let's find out who's at risk. Let's start to kind of collaborate with the churches. Let's collaborate with the behavioral entities and the coordination arms. You know, we have GBON. We have about 240 employees. We have an IT infrastructure that can handle 2,000 to 3,000 calls. We have a call system. So because we are focused more on large scale, it was not a big issue for us. Our call center was getting calls that we were able to kind of, and I'll show you some examples of way to really touch people and get the information out. But once we found that individuals were positive, then we were working. And when I say we, JABACA, which is an accountable care organization, has about 250 providers, but two groups were heavily penetrating the east and the west side, ourselves and Jericho. So we came together and we were just kind of helping each other. If they didn't have PPE, we had PPE. We kind of did that. We were swapping staff if we needed to. We were kind of plotting where to look at the zip codes. We took our data and really started to focus on who to treat and what information to get out there. Once the patient came back, Jericho was better equipped with respiratory assessments. So we were shifting some of these individuals to them so that if you were COVID positive, we can monitor and see if you were going to get into trouble to decide what next steps to take. But I think, though, the one thing we wanted to do that we weren't able to do, was to really develop a location for smart isolation. And while we haven't done it, I think with the phases that are with September, fall, when we're going to get this thing back again, that is an area that we're going to need to focus to be able to really channel and isolate people that may be carriers. And at the same time is, if we do start seeing more cases in the hospital, which we are going to see, is how do you get them out of the hospital into a location and not send them back home when they still potentially can be affected. So these are the areas that we focus on. Once the testing was done, we were connecting them to their primary care, our primary care, through a telehealth model. So we didn't care who it was. It was a lot easier that they called the nurses because the protocol was in place. You can gather the information. Then they just came in and tested. And you'll see it later slides, how that information was gathered to really get a firm assessment of what areas we were targeting, who was positive, and breaking it down on a lot of the demographics. Next slide. I think here is that we kind of showed that we went from that telehealth on the left side, and when it came March, we shot up. Almost 100% of our visits were virtual. Interesting because patients became better, they liked it. They were communicating, if not video, we were catching them through phones, but we were telling them to stay away from the emergency rooms. We were just giving them information. So we told everybody, stay home. We told everybody, that this is it, but we were able to communicate, what are you doing at home? When you enter it, when you're there, when you leave, and if people were positive, what things they needed to kind of look at for other individuals, because you might have gone through your 14-day course. Early in the virus, we found that this virus stayed in the stool for 21 to 28 days. So we were saying not only as a respiratory, but you're also looking at fecal oral. So how to really do a better job with that, connecting them with their primary care was crucial. In addition to talking to them and getting them set up, what we'll show you some apps that we were able to kind of get the individuals to fill out, and it would be channeled back to us. Because when we ran out of testing, it was a good way to kind of get people ready for more testing when it came in. Next slide. And I think these were the things that we worked with the churches. It was great because we were able to kind of put them on our platform. So when they came out, they had chase lists, and we just put them on our platform. So we tracked when people needed food, when they needed behavioral services, connecting them with the behavioral entity, when they needed testing, the church and their members. Remember, there's about 204 churches. Am I close to that, Reverend? I mean, there's a lot of churches, and the zip codes are so important in terms of the lives they touch, in addition to they're trusted. So if they're calling, they're going to get a better response than anybody. And that's why it's so important. But the teletriage, in some cases, when we have the PPE, we were able to send out equipment that if you had a COPDer, we could listen to lung sounds, heart sounds, visually, almost creating a virtual visit and managing that person. Our Skype system was able to kind of bring different specialists in. So, you know, at least get them comfortable and make sure that if they had food, because we had a pantry, we had pantries around the area, we were able to go to these homes and really provide those services that were so in need. And this came about not because of any funding of any type. I mean, you know, the health home was built on the Affordable Care Act, and it helped to do that. The rest of the entities, everybody was just kicking in. Nobody was complaining. But we did not get any funding for this, in a sense, to really do that in the beginning of the process. Next slide. I think this is just an example. Those are the equipment that's used. And this is prior to COVID, so, you know, she's not using the equipment, but it's real important. We had COPD patients, we had pregnant patients, that what we were telling them is, don't come in. You know, if you're sick, we're going to go see you. Because in the old days, the doctor, when you were sick, the sick people did not come in. You took care of them at home. So we just went back to that model. And what was important is we had COPDers that were having trouble, and we didn't want them to kind of go through all these barriers. You get on the bus, you're going to be exposed. By the time you came into a waiting room, you were going to be exposed. We found to really redirect and treat these individuals at home with partnership of multiple doctors. So a lot of doctors that normally don't work together, we were pushed into kind of, you know, the test was done, here's your telehealth, and if you got issues, we can help you with the call center on our side. Next slide. These are the apps. I mean, so we had a Jabonco, Gbon, and Urban app that we've had for a while, but on the left side, we had a contact tracing survey. So it would give us an idea and we had the data already on our demographic, but these are for people, patients that weren't part of our system. We would know who they were around to begin to decide who else we needed to test. The number 2 was a social determinants of health survey. And it talked about food and a lot of the requirements. So we were able to kind of reach out and make sure that, yeah, you're in this place for 14 days, but these are the things that we're going to get to you so that you're okay during that time. The last one, the COVID-19, basically was a screener that gave us the idea whether, you know, whether someone was needed to be tested. When that was done, one of our nurses reached out to them. Next slide. I think one of the other things that we've implemented and we didn't fully execute, but we're going to do, is what's called this Halon connection. What it does for doctors in the electronic record, when you're in the chart, this pops up with a lot of information, but you can instantly create a referral system for the CBOs, community-based organizations, or the churches without having them build an electronic record. Next slide. And what you can do on this slide is really you create this almost internal Outlook system, but you can drop in, it's HIPAA compliant. We can track the referrals, making sure it's being done. 50% of referrals that come out of a primary care office are never finished. And as a result, it adds cost and poor quality to people. And this is a way that we started to, and we'll, in September, God forbid we run into this problem, we're going to be using this more to tie in systems so that they don't need to have electronic information. Next slide. I think these are some of the, we have a lot of data. We have our own premise cloud. So we're able to kind of really look at, people in a lot of different ways. This was really good. So this was on a Healthful side. The next slide is the one we use for the ACO, similar in terms of format, but we were able to develop, next slide. Yeah, we were able to develop, so the chase list that the churches got, we put all that information in there. They can call, the calls are recorded, HIPAA compliant and all this process. Everything they did, whether it was food, whether it was testing, all the data was captured here, and at any point could be really passed over. Gaps, if people were being called, I mean, we were helping people get set up for voter registration, census. We were trying to tackle all those things while we had them on the phone. But then we worked with the churches to kind of give them the medical view of things. So if they did a PHQ-9 and they came back abnormal, you know, make sure Endeavor was involved. They help with the counseling components, which are crucial in these communities, because mental health is high. And sometimes not addressing it the right way leads to a lot of bad outcomes. And I think the church really has a great place in this space. Next slide. This is an example of what we did with the contact tracing. Because we have all the information on these individuals and it's accurate. I mean, if you have that, like the county and the health department, a lot of people change numbers that, you know, when you try to pick up, you're not going to be able to do that. But because we have that personal relationship with about 8,000 lives on one side, we could reach out. And this is what we were doing for the contact tracing when we got people being tested for COVID-19. In addition, we, you know, within the 15,000 lives, because of the model that we follow, we unfortunately had just one death. One's too many, but we did have one death. But we were analyzing the mortality data, which I find that the county and the Department of Health really needs to kind of look at close up as to what happened with the individuals that died, whether, you know, the coagulopathy would develop or the cytokine storm, whatever the pathology was, you know, what levels of antibodies they had. All that information is very precious that can really help us when we unfortunately get into this issue again. Next slide. And these were just flow shots that we were using care coordinators, and they had a flow chart so they know exactly what meds people were on. Interesting enough, we found that the areas that were often hit hardest in the 14215 was patients that didn't have primary care. So they had the hypertension, they had the diabetes, they had the asthma, and that's what they ran into a problem with. What we found is the patients that were on hypertension that we were treating with ACE inhibitors and ARBs, that particular drug reduced the receptors in the lung. So it was protective. We found that a lot of these individuals that had other exposures that were on that, because we were doing the science at the moment, that was very helpful. People that were asthmatic that were on the inhaled steroid, we kept them on. We were given the dexamethasone when they flared up, and we found that those individuals were actually doing better as a result of that. But it was all because we were looking at flow charts and really understanding that population. Next slide. This is a little bit of the data. So this is the antibody data that we did. Almost, we're up to about 1,300 tests that were done. The zip codes where they tested positive, the areas that we tested are on the bottom portion of that. We have about a 5% positive rate within the population that we've been testing. You see the breakdown of African Americans that were positive, of other ethnicities, Latinos. So, you know, you start to begin to see the antibody response. The next slide is the actual nasal or the COVID test, which we are at right now. And this all data is being pulled in. So as the tests and things are happening, all these things refresh on a weekly basis. We're at about, you know, almost a 5% rate, again, on the PCR. Again, giving us a good feeling, mapping out where we need to kind of pay more attention to. The next slide gives you a combination of both of the tests. So we've tested over 2,000 people. Jericho's tested close to 4,000 to 5,000 people. Our data tells us different things. So while I have my view, Jericho is seeing a certain population, like the Burmese population, that's really higher than the rest of the population. They were running rates of 25, but we were communicating back and forth. The issue that we have now, which has to be, and I just spoke to some of the channels, is that we're in the phase 4. We're thinking of opening up schools. The problem that we have is now where Kaleida was a partner providing us testing reagents to do this stuff, they stopped doing that as of last week because they can't get any more. And Quest, which was our alternative to test for COVID-19, is backlogged 14 days. So if I test you today, it's going to take 14 days to get back. All those things are going to be a major issue. If we do stop doing this thing, in 14 days, the 1% rate that we have right now in this county is going to be close to 3 to 5%. And I would not want to see schools opened up. And this is the kind of feedback that, you know, the county needs to hear about. I think the ministers understand, so that we all kind of learn from it. It's not like we're throwing anything, like saying anything bad. We're seeing something on the ground, grassroots, on a day-to-day basis that can help us all. Because if one county or one zip code is hot, you know, everywhere else is going to be affected, and we don't run into the same things that are going on across the country. Because once you get to the point where you have large amounts of infection, you know, contact tracing is not going to work, and you're pretty much stuck with a health system that it wasn't equipped to handle COVID types of episodes. I think that was my last slide.
Great. Thank you very much. And I think you obviously mentioned, you know, a number of points where there has been collaboration and a role, and we heard at the beginning, you know, particularly for the counties. So if we could turn it over to you, Maria, to really share, if you want to go back to some of the earlier slides to share the actions taken, the partnership. You know, we're already hearing a tremendous amount about the great collaboration that went on.
Thank you, Meg. I think probably the next slide is the best place to start. I really want to thank you, Meg, and Reverend Gundersen, and all of you that are participating in the webinar today. Thank you so much for your interest in our story and in our community. And I also want to thank my colleagues on the panel, Reverend Nicholas and Dr. Vazquez. It's been just a pleasure to call you partners in this effort, and I look forward to our continued work together. I think if you just back up and take a look at the slide with the trends there, really what this slide is meant to show is to demonstrate where we were at the beginning of the pandemic and how we progressed towards the middle of June. And then I did send over, I'm sorry it's not included in the chart, but I did send over to Meg our most recent data from just Friday of last week, which indicates that we are still hovering at a fatality rate among African Americans due to COVID-19 at just around 16%. So I think if I could just reflect on sort of the top 3 overall things that helped contribute to this downward trend. The first is really a significant commitment to transparency around the reality of the data. And I say that because that is not true everywhere in the country. I tried to do research myself, and with the help of a research assistant here in our office, documenting what the fatality trends among African Americans and people of color from COVID-19 were in cities across the country, particularly municipal regions that were similarly sized to Erie County. Our population is approximately 930,000 people, so around 1 million people. And so many places are not even capturing this data. They're not reporting on the data. They're not documenting the death rate by race or by zip code or some very important demographic trends. So having that real commitment to transparency around the data was key. And Reverend Nicholas, you know, reached out to the county executive very early on and really encouraged the county to be very transparent about the specific data relative to COVID-19 fatalities. And I'm just going to share for the group.
Sorry, Maria, you muted yourself.
Unmute, Maria.
Sorry, apologize. I just wanted to share in the chat function a link to the map that Erie County created. This map was developed by our GIS division as the Department of Environment and Planning, and it is a map of all of the COVID-19 cases in Erie County, and it is broken up by zip code. So it is important. Anyways, issue number 1 was the transparency and the commitment to the transparency. Issue number 2 in changing this trend was really the political and I think community will to work together to change it. There had to be a will to change it, to understand that this is an unacceptable rate, to be transparent about the data, to acknowledge that the data signifies a great disparity, as Reverend Nicholas talked at length about, and that there needed to be a political will to do something about it. And then the third thing was really creativity in, what will we do about it? What strategies can we employ? And of course, you've heard at great length from Dr. Vazquez about the many things that his clinics in particular did to help tackle that reality. And so what were some of the other things that partners outside of the healthcare provider system specifically might do to creatively dig into this? And it meant really going deep on some issues. For example, transportation to testing locations was identified as a barrier. And so, we had to dive deep into that issue. And we, in the end, established a practice of taking the test, using Erie County health nurses and our county Department of Public Works vehicles and taking the test to the individual. So, in addition to the clinics set up by Dr. Vazquez that had mobile testing units, we also had a public health system that would take the test to the individual for people that had significant barriers. So I think those were the 3 things. Going back one more slide, please, Alina, the previous slide, the partners to be engaged in the trends. You can see there the wide variety of participants. Obviously, Dr. Vazquez's clinic, Jericho Road Medical Center, which Dr. Vazquez referenced, many of the churches that Reverend Nicholas talked about, the city, the library system, the Kaleida health system. Kaleida is one of the larger private healthcare systems in our community. Many of the local labor organizations were involved in helping to support this. Why? Because they represent a good number of the workers that were finding themselves at greater exposure to the coronavirus. So we were lucky to have engaged the local labor institutions as well. And then if you go to the next few slides, and we don't have to go in great depth to them, I do want to save time for your questions, but slides 7, 8, and 9 identify the actions taken. And just to kind of illustrate some of the creativity there, one action taken by the chairwoman of the county legislature, she reached out to those labor unions. She asked them specifically to identify how many essential workers they had in the 3 zip codes that had the highest concentration of COVID-19 cases. How many workers did they represent in that community that were essential workers? So again, people that were physically going to work, that were not able to be working from home, that were increasingly exposed to the virus. We had more than 5,500 essential workers in those 3 zip codes alone, which demonstrated the kind of aggressive action that needed to be taken. Another, I think, creative step, which is maybe on the previous slide, Alina, was something that Reverend Nicholas, through the Buffalo Center for Health Equity and the partnership with the many churches took. They created a phone bank system, and Reverend Nicholas could talk way more about this than I did, but a phone bank system using data from the Board of Elections. So you may know that at least in New York, that's all publicly available information. When people register to vote, they often include their phone number. Sometimes those phone numbers are not still accurate, but many times they are. And Pastor Nicholas and Reverend Pointer, sort of co-chairs of the Health Equities Task Force, collected that data from the Board of Elections and then engaged in a phone bank, contacting literally tens of thousands of people, to reach out to them, to kind of conduct wellness checks, to connect them with primary healthcare clinics, to make them aware of the testing availability that the county was doing, or to help them get PPE if they needed it, and to identify other needs. And Reverend Nicholas and I had many a late night conversation of, oh, this is what we found out on some of these phone calls, Maria. We do have these transportation barriers. We have to help solve this problem. So that was those phone banks were a great way to not only provide solutions, but then to also get really in the moment direct feedback from people in need about what they needed, so that I always say in the county, I want to spend my effort and our resources, and not just my effort, the effort of county government, to solving the right problem. But in order to solve the right problem, you have to have proximity to the problem. And being in touch with folks like Reverend Nicholas, who conducted these phone banks, helped us maintain that proximity to the problem and really make sure we properly understood which problems needed solving. And then I think maybe the last thing that I just wanted to share is we did have a research assistant in our office provide some additional research on other municipalities across the country, similarly sized to Erie County, so a population of roughly 1 million people, where they were tracking data on fatalities from COVID-19 by race. And I'll just point out a few of them. In St. Louis County, Missouri, African Americans represent 25% of the population in St. Louis County, which has a total population of 994,000 people. African Americans represent 25% of the total population there, but 39% of the deaths. In Milwaukee County, Wisconsin, population 945,000 people, so just about the same size as Erie County. African Americans represent 27% of the population, but 40% of the deaths. In Macomb County, Michigan, which includes the city of Detroit, overall population, again, of about 900,000 people. African Americans represent 12.6% of the total population in the county, but 20% of the deaths. So it is important that you track this data. Many other places that we tried to look into, which were similarly sized, they're just not tracking the data. So we don't know how those communities are comparing. But I guess I will just close by saying that, the focus on the social determinants of health, as indicated by Reverend Nicholas, as indicated by Dr. Vazquez, is really essential. And although COVID-19 has exposed the greater cracks in the system there, those cracks were already there. They were already there, and Erie County itself was already working on that. We had a project that we launched last September called Live Well Erie, and I will share via the chat function a link to the Live Well Erie website. And that is a partnership of more than 90 community organizations, nonprofits, etc., businesses as well, that are dedicated to really advancing the social determinants of health that would help eliminate many of these disparities. And our Live Well Erie partners, it's there on the slide now, issued a statement in the early days of COVID-19 talking about how the social determinants of health make the exposure to the virus and illness, severity of the illness relative to the virus much greater. So with that, thank you again for your interest. Thank you again to my colleagues on the panel, and to Meg and Reverend Gundersen. We're so grateful for your interest in our work, and we know that we have a great deal more work to do, as Dr. Vazquez talked about, among the refugee community, among certain pockets in the community, a great deal more to do, but we are on the right track and trending in the right direction.
Maria, this is Gary. Oh my goodness! When we had seen the content begin to emerge in our planning calls, I kept thinking of this as a jazz trio that really knew all the risks and knew how to complement. Among other things, y'all landed perfectly on time, which opens the space for folk on the line to engage with you and follow up. I do want to ask one question, since many of the folks participating are in the business sector, and there's been a good bit of talk throughout the pandemic about essential workers. I'm curious about essential companies. Who were those 5,500 essential workers working for? And talk a little bit into this space of the business community as a critical partner, if it was. So I just want to open that, and then I'm sure we'll have some other things to open up. Probably Meg will follow up.
Well, a lot of the, let me jump in, then you grab it, Raul, but many of the essential workers come from some of the existing healthcare facilities that we have within the region, our hospital systems, nursing homes, and also we have a huge home healthcare aid population here. And so, and the vast majority of those workers come from the African American and Latino community. A large majority of those people live in those zip codes that we were talking about. So some of the early findings that we were seeing is that people were going to work, didn't necessarily have the proper PPEs, getting exposed, and then coming back into their neighborhoods, into their communities, and then spreading. So one of the things the business community has been good at is responding to the call to help us get PPEs and get them into the communities. And so, you know, I've had a number of partners in the business community who have, you know, come up with resources or use their resources. So for example, I think of one neurological who says, listen, you know, when we do an order, we'll order more so we can get, you know, then we'll drop off some into your community. So folks have been really good, and they've been really good on the food side. One of the things that we didn't really talk about too much is that, you know, there's a tremendous issue of food insecurity. And so part of our project, you know, we purchased about $200,000 worth of food and distributed to people within our communities, and that number is ongoing. Raul, do you want to grab anything else, or Maria on that?
Yeah, I think, you know, I think for us too is, you know, so GBON, you know, we had 240 employees that are all essential workers. So, you know, it kind of helped. But we were just protecting. The PPE was very difficult in the beginning, but at least we were able to kind of, and like Reverend Nicholas said, we bought stuff at bulk, and we were able to, so as people came in for testing, we gave them a little goodie bar. The one thing we did have trouble was with thermometers. We could not get any thermometers. So we had the hand sanitizers and the mask and gloves and things like that. But yeah, not, you know, because the essential workers were all over the place. I mean, there were the bus drivers, I mean, ambulance drivers. I mean, they're the ones cleaning. They couldn't stop, you know, they couldn't stop. And they were also economically, they couldn't stop. So it was just that we saw that. And then the multi-generational families that we are all in with the home structure that doesn't allow for a lot of movement. And if you have someone that's infected, the likelihood is there will be more infected in that system. I think for me, the other thing is my daughter in March, my oldest daughter got COVID. And so I really learned, I became a virologist and an infectious disease because that was my baby. You know, I had to really know everything about it. I couldn't live with myself if God forbid something happened to my baby. So, you know, you learned a lot, but yeah, not all the other thing is not all medical offices were equipped to go telehealth. They shut down. They were in chaos. Patients didn't know who to call. So it's a sort of a wake-up call to really kind of at least invest in primary care and public health within these communities, because I think social determinants of health, these three inexpensive ways that can be kind of develop some sort of funding through the county can really have big return on investment. Because, you know, when this is the new world order and we're going to go through this type of a model, we need to kind of invest. We need to invest and digital divides. So we have areas in the community that don't have any access to internet. When you have education going on, they couldn't be connected as well. And if we had more of that system, we could do better, monitoring of some of the individuals that really don't have to come in and to these offices and be managed. If we can do a lot of these things at home with wearables. So I think it's an opportunity to really redesign things. But yeah, that's my short answer.
So Dr. V, first I have to ask, how's your daughter doing?
No, she did really well. I think I learned so much on the pathology of it. So this is the thing. She was tested. I took her to an urgent care. Then she got worse over that week. I mean, she had fevers of 104. She wasn't eating, and I didn't know what, I was like, okay. I took her into the hospital. She was retested. We still didn't have the result of the first test. And while she was there, she had this pneumonia that we decided to treat with Levaquin, which is an antibiotic. It comes out that when you get this type of pneumonia with this condition, you get atypical bacteria that grow. So she responded. Within 24 to 48 hours of IV antibiotics, she got back to normal. We took her to the house, still not knowing what the results were, following all precautions in the house. She was isolated in that place. We found out about the test 13 days later.
Wow.
So it could have been a really bad outcome with the rest of us. Me and my daughter are ACE inhibitors and ARBs. We didn't catch it. No one else. We did antibodies on everybody after this whole course, and only her antibodies came back positive.
So let me ask a question to point us in a different direction. First, I'm just as a dad, I'm really hearing your story and the way that this is. This bug is a real nasty thing at family level. But let me ask this. So Buffalo's a tough town. And anybody weak and lazy has left Buffalo a long time ago. So I'm not surprised by the intelligence and creativity and grittiness of the story that the three of you raise up. But some of us live in easier towns. I'm a little curious about what the three of you would say amid COVID about how COVID is sort of stress testing the relationships in Buffalo that might give us some counsel about the capacities in our towns to do unprecedented work. I mean, anybody's lived through a Buffalo winter, it's tough enough for a pandemic. But many of us live in maybe easier towns. Some of us live in towns we think are as tough, but probably are not as tough. So what have you learned about collaboration that points to a future that might help some of us to see our own towns in different ways? And might be Pastor, might be Maria. I'm just fascinated by the three of you being in close but different sectors.
I'll just start. Know what you want. Maria will tell you in our conversations that I've been a part of, in terms of as we talk about what's going on in the Black community, you never have to figure out what I want or what I'm trying to do, right? I mean, you got to know what you want and be very straightforward and blunt about it. Nobody's got time for just talking around stuff, just boom. And then appeal to what people can do. So in our conversations with the county executive, I never asked him to do something that he doesn't have the authority or power to do. But then if there's an area that's beyond his power, but not beyond his influence, to get him to use your influence, you can do this. So this you can do within your system. So give me that. Now this, I need this as well. So now use your influence to help me get that as well. And always have it connected to what the original issue is. So I remember a real quick story. Maria and I were working with a group of folk around a certain event. I'll do some talking around stuff, Maria. And we came to an agreement, Maria and I and the county executive. But then some of the other people at the table decided to go in another direction. and not tell us, right? And so what was important was that the county and executive and I and Maria talked about that. And we stuck to what we were gonna do, right? Because we had an agreement, this was the path that we were gonna take. And some of the other folks around the table wanted to do something else. And so we weren't gonna stop them from doing something else, but we weren't gonna be part of that, right? And so you have to operate with a level of integrity. You gotta be clear about what you want. And you gotta do what you say. You know, a lot of times, you know, we've been around, around a little bit, and people will not do what they say, and then get mad at institutions, right? Because they didn't do but you didn't do what you said you were gonna do, right? And so there has to be this level of mutuality, of respect, of integrity in our working relationships, and know that there are going to be times where we don't agree on things, but we're not going to walk away from the table. We're going to continue to work on those big problems, and we might have some crisp words on Tuesday and laugh about it on Wednesday, because we got these issues that we got to. It's all about the work. It's not about our feelings. It's about the work. And so that's, I don't know if that answered your question, but that's kind of how we operate.
Yeah, Pastor, early on in your very early comments, you comment about the relationship with the university and not being naive about history, but not letting history entirely write the future either. And I'm curious about other sectors that applies to, other business sectors in Buffalo who, so we sort of spoke a little bit to the whole healthcare sector, some of which is for profit, some not.
Yeah,
but
let me,
what do you see as the possibility to engage people who in the past might not have been able to engage, but now you see a chance?
well, let me just say something. This is Dr. Vazquez, more on the healthcare system, because, while we have the Black Lives Movement in the police system, we have the same thing that goes on in healthcare. And I think I've been in this field for 30 years, and Black and brown patients get treated different. I think hospital structures across the country have really focused more on really profit, elective procedures models, and they put all their eggs on that, really not doing the work they need to do within communities and really developing a community-based model. And I think when this hit, if you don't diversify your portfolio and you put everything on one stock, it has become sort of really catastrophic for the Mayo Clinic, for the Cleveland Clinic. You're talking big systems that have lost billions of dollars because, again, we are focusing our energy on elective procedures, and those need to happen. But I think you need to really focus on community-based models to help with prevention, help with social disease, help with primary care. Because those elective procedures, a lot of them are complications to just treating sick care. We got to focus on well care. And I think maybe going forward, funding needs to be redirected to do that, because Mark Twain's definition of insanity is what we do today in healthcare.
So Maria, I'm curious about your day job is maintaining relationships among very complex stakeholders, many of whom don't understand each other. So this, the trio that's playing today is a small part of the band you have to respond to and deal with. I'm a little curious about how COVID has affected some of your other stakeholder dialogues, especially, again, with the business community in Buffalo.
Well, there's no question, Reverend Gundersen, that COVID taxes those relationships, and it taxes them in lots of different ways, in part because existing problems and fissures or distrust, any of the things that cause a relationship under normal circumstances to be fraught or difficult is just made worse by the challenge of a pandemic of this size and this magnitude. And it's made more difficult in part because resources are scarce. It's made more difficult in part because you know, people have been exhausted working, you know, and I saw this in the county executive. I mean, he worked nonstop for weeks, and the health commissioner for weeks, you know, like so many of us that were part of the essential response team, you know, you are only human after all. And the demands of the job were as great as I have ever seen them. And so, so how do you get through the taxes on those relationships? Just with the things that Reverend Nicholas has said. I mean, trust comes down to any effective relationship is only as good as it is by the trust in the partners, by the integrity of the communication, the honesty, the following through. I mean, those, you know, and then you recognizing where people are coming from. You know, the anthropologist in me, my undergraduate degree is in international relations and anthropology. So I personally am really good at asking questions that help me get to know people and where they're coming from and better understand their objectives and, you know, how those objectives align with the county's objectives or what we can be doing together. But I think your question, Reverend Gundersen, is an honest one, and COVID-19 has taxed those relationships, but we have managed through it in part because of the integrity and trust of the actors that are undertaking the actions.
Maria, if I could maybe ask a follow-up on that. You know, one of the things we've heard on prior webinars is that county public health, county executives, you know, everyone within communities are just, you know, incredibly taxed with regard to their capacity to address this. And you all have really showed how you've really made the best of the resources you could have to focus on a problem. But a couple of follow-up questions for you that came in via the Q&A. One is, what are you doing, and also for others on the panel, what are you doing to try to build capacity? Are there initiatives at, you know, in other counties that you've engaged with to try to do that? And I think lessons learned for others that are listening to, following on a question that Gary asked, you know, advice and guidance about, you know, how to kind of get those resources or that capacity to sustain yourself going forward, because it's clear you want to be doing much more. So kind of, how did you build the capacity? What are the lessons? How are you going to try to sustain it?
The short answer is with great difficulty. And I mean, I can't help myself, Meg. I have to just comment on the failed federal response. I mean, you know, our purchasing director early on, Reverend or Dr. Vazquez and a number of the other providers contacted the county for supplies. Our purchasing director, Erie County, New York's purchasing director, was directly negotiating with Taiwan for supplies. Why? I mean, you know, to steal a slogan from the labor movement, united we bargain, divided we beg. So we are either united as a country with the purchasing power of the federal government to get the resources that the United States needs to directly respond to this crisis, or we will just be divided. And Erie County, New York will try to outbid St. Louis County, Missouri for the whatever we can get from Taiwan. I mean, it, you know, I can't help it. The frustration there is real. When you're asking me about the capacity, the moment for me in which I cracked early on, you know, and obviously not permanently cracked, but in which we had a broken moment was, you know, the financial reality of the county's fiscal. I mean, we just cut $138 million from our budget. In the current year's budget, we are facing another $100 million shortfall. You know, like, I mean, the capacity to solve those problems depends in part on resources, and the federal government is not bringing those resources to bear. So what have we done? You know, instead, it is not just the function of government. And as you see here with Reverend Nicholas and with Dr. Vazquez and so many of the other partners there, how do you build capacity even in an environment like that? Through partnerships, meaningful engagements with other people that are prepared and able to lead, and who, you know, who are mission driven and connected. You know, I talked earlier about the proximity to the problem, you know, to make sure we're solving the right problem. So you have to have partnerships with people that are proximate to the problem. And I think, you know, the building capacity and the lessons there that comes from not just relying on the federal government, because they have utterly failed in many ways. Certainly the CARES Act funding in some ways has been helpful, but we are still waiting on the state and local government relief package. And so the lessons there, the building there, that comes from these very effective and meaningful partnerships with people already engaged in the work, who are also challenged with resources as well. I think that's my answer in a nutshell.
And, you know, it seems, you know, just to kind of ask the other, thank you, because I think your directness and your honesty to me emphasizes even more just the incredible capacity and the partnership, as you say, that you've put together, which, you know, got you to this point. We did have, I don't know whether the others want to speak to it, we did have one other kind of practical set of questions that came through, which is going forward in terms of thinking about things like masks and testing and distribution of thermometers and so on. You know, kind of thinking about how if resources are monetarily constrained or there's less access, where do you see that? You know, one of the audience members really wanted to understand how that activity is going to be sustained and whether businesses would be involved. So, you know, further distribution and so on. So a very practical question that was asked.
So one thing you have to remember that, you know, COVID-19 hasn't driven all of our work. I mean, we've been working on social determinants of health for 5 or 6 years. And, you know, Maria and I have been engaged in conversations about racial equity and stuff for many years. And so we've been able to stand up 2 organizations here in Buffalo, the Buffalo Center for Health Equity and the Research Institute at the University of Buffalo it's going to be focused around health disparities as well. And so we're going to continue our work, and we're going to continue to reach out to the foundation community. You know, we have good relationships with the foundations here in Buffalo. We're reaching into and we've already reached into the National Institute of Health, CDC, other national foundations. So we're really, I mean, I don't want not to be flippant, but, you know, Black folks have always been in crisis. We've always been challenged for resources. We've always been, you know, just trying to, you know, as they say in the church, make a way out of no way. So this is just another challenge in our story of Black America. And we're just gonna keep working hard, keep pushing, because at one level you're right, Maria, there's this resource issue, but the last time I looked, the wealthy have made more money during this period. And so there's gonna have to be some really serious conversation about shifting some of the wealth that was generated in the midst of a pandemic and investing some of that wealth into helping vulnerable. And Reverend Gundersen, I read in a book somewhere that we're supposed to be concerned about the least and the lost. Some guy said that. And, you know, I think we ought to hold people accountable to those words and do that. So at one level, yeah, there's this concern about resources, but it's not because there's not resources in America. The resources just aren't in the hands of the people that it needs to be.
So Pastor, the Jewish carpenter you're referring to was best known as a healer. And that's what I've heard in all of this Buffalo story. I'm curious from I may give you the very last word that I was going to take, but I'm curious about how the profound and complex nature of the crisis that we're living in has to take us beyond the word social determinants. And I'm inviting you to reflect on whether these are really psychosocial, political, but most profoundly spirit determinants, and whether what we're seeing in Buffalo is the way that those determinants are not all negative, that when you have eyes for the community you love and care for, you can find in all of those domains extraordinary power and positive assets to work with. So what I'm hearing in the Buffalo story is psychosocial, spiritual assets aligned and in a very powerful way in service of the community that, well, I'm a reverend, that God so loves, but I could tell that people in Buffalo love their community in a way that's quite profound.
Yeah, I mean, this, you know, for me, there's no separation of my spiritual practice and this work, you know, and so, you know, sometimes because I am a little bit visible on activism in this community, and sometimes I have to remind people that I'm there, not in spite of being a minister, but because I'm a minister.
Yeah, thank you.
And that we all have a call to be concerned about our sisters and brothers. And we can't, for too long in this society, in this culture, we have walked to the other side of the road and have not stopped to care for the person lying on the Jericho road. But my challenge for people to do is not only care for that person like the Good Samaritan did on that road to Jericho, but I invite people to walk down that road and find out what happened, who beat that man, who put that man in the condition that he's in, so that we can deal with that person as well. Because we got to do more than just pick up bodies that have been broken. We need to do that, but we also need to find out why and then deal with those why issues. And that's when you talk about the fancy word social determinants of health, but it's really just, why are people not able to enjoy the fruits of the land? And it's not because of a divine action, it's because of man's greed and selfishness. And we have to do something about it.
Meg, back to you.
Thanks. Well, we have we've reached the end of our time. And, I think that unless Dr. V or Maria, you have any closing comments, maybe just to close on that great message. And, I think from everyone who was listening in, what we will do is, if there were some additional questions that came in, we will try to get some answers for people to post. But I just want to thank all of you for what you've accomplished in terms of the partnership, but particularly in terms of really, one of the questions was, how do we go forward beyond COVID? And I think you are inspirational in terms of grappling with an issue that COVID made even more prominent, revealed some very, very significant fault lines where you didn't step aside from the lack of resources or capacity or the need to ask the difficult questions. You jumped in and did it. And it seems that that really has inspired everyone within Buffalo in an effort to keep going forward. So I just want to thank each of you, and you, Gary, as well, and everyone that participated. It's an inspiration. And we hope there are many more people out in the country who are very similar to you. So thank you for sharing your story and your actions with all of us today.
Thank you.
Thank you for this opportunity.
Super.
Thank you. And, you know, my last words, you guys can do this too. Just be bold. Just be bold, know what you want, and just go after it.
Great.
Thank you, Pastor.
Meg, you're welcome to share at least speaking for myself, to share my email address with any of the participants in the webinar in the event that they wanted to follow up with questions. I don't know if that's something that you do, but you certainly are welcome to.
Thank you very much. When we post the slides, which by the way, do have your new data from July in them,
Oh, great.
we'll
Okay.
make sure that on the last page, we include each of your email addresses and contact information so that if anyone does want to reach out, we can go ahead and do that. That's a great offer.
Awesome.
Super. Thank you all so very, very much.
Thanks.
Thank you.
Bye.